So welcome everyone. This is our third of our 4 lecture series that we've hosted for the Rochester Marquette Challenge. So thank you all for coming today and listening to our guest presenter, Dr. Megan Gill. Before I turn it over to her, I just want to go over a couple announcements. So please keep yourself muted and your video turned off throughout the presentation. And we will have some time for questions at the end of the lecture. So if you have them at any point, you can go ahead and put them into the chat box and we will get to those at the end. And then just a reminder that we organized this lecture as part of a fundraiser. So there will not be any continuing education credits awarded, but we do ask that you donate a minimum of $5 for attending, and I will put that donation link into the chat box shortly. So I will now introduce Dr. Megan Gill. Dr. Gill is a clinician researcher at Mayo Clinic Rochester in Minnesota in the field of physical therapy for individuals with spinal cord injuries. She has worked with the CSI population for 15 years and currently works on research activities geared to recovery of motor activation and locomotion, specifically epidural stimulation and exoskeleton gait training. So go ahead, Dr. Gill. Thank you for being here.
Thank you. First, I want to thank Haley and her team for the invitation to speak today on specifically 2 topics that I'm passionate about. Number 1, spinal cord injury, but also to highlight, number 2, the fact that physical therapists can have a vital role in the field of research, specifically neuromodulation. So that's what we're going to talk about today is task-specific neuromodulation training for individuals with spinal cord injury. So the objectives of today's talk are to review the current status of neuromodulation and spinal cord injury rehabilitation in today's clinical practice. Then we'll review and describe epidural stimulation as a form of neuromodulation, and then review the functional gains that have recently been published and in the media for those with spinal cord injuries while using neuromodulation pertaining to motor functions. So first, I'd like to set the foundation and give a good description of what some terminology is. And so neuromodulation, as defined by the International Neuromodulation Society, is described as the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or a chemical agent, to specific neurologic sites of the body. So in today's world, some examples and types of neuromodulation that are used in our clinical setting include deep brain stimulation. And you can see in the picture here on the top of the screen, deep brain stimulation, also known as DBS, uses a specific electrical therapy implanted into the brain to reorganize and to control some of these imbalances that are occurring within the brain, very specific to a tremor or epilepsy. There's a pharmacological delivery of medicine that's used through neuromodulation, where we're specifically delivering a consistent dosage of medication to the central nervous system. Most notable is the baclofen pump therapy. It's used for patients who suffer with spasticity. Transcranial magnetic stimulation is the use of the magnetic field on the brain to target specific areas of the brain that are either hypo or hyperactive, specifically seen in depression. And lastly, we talk about today is spinal cord stimulation, which is typically used for chronic back pain or those that have a neuropathy due to other injuries. So let's describe and define what the spinal cord injury is. All right, the spinal cord injury, according to mayoclinic.org, is damage to any part of the spinal cord or the nerves at the end of the spinal canal, often called the cauda equina. And damage to these nerves or these neurons results in oftentimes permanent changes in sensation, strength, or other body functions below the injury site. So when a spinal cord injury happens, one of the few main things that we need to emphasize is measuring and classifying the level of injury and the severity of injury. Level of injury can be defined as either a tetraplegia or paraplegia, and that's determined how many limbs are involved due to the injury. Tetraplegia, also described as quadriplegia, affects arms and hands, as well as the trunk and the legs, whereas paraplegia affects only the trunk and the legs, and the arms are not involved. Describing the severity of the injury doesn't describe the level of trauma, the structural trauma to the spinal cord or the vertebral bodies, but more on the neural pathways that are open and available to communicate from the brain to the muscles or the skin. And we describe the severity to be either complete or incomplete. Complete being all sensory or motor functions are lost below the level of injury, versus incomplete, there is some retained motor or sensory function below the spinal cord injury. We define and describe or diagnose these severities based on the INSCI exam, which is just the International Standards for Neurologic Classification of Spinal Cord Injury. It's a detailed exam of looking at motor, as well as light touch and pinprick sensation throughout the body. Going through this detailed examination, as well as looking at the rectal tone that exists, we can then define the severity of the injury and measure it as either an ASIA A, ASIA B, C, or D to help us predict the level of recovery that we can expect moving forward with our patients. The level of prediction is really important for us, not only to help us understand the medical model or the therapeutic model to support these patients in, but also to help us understand in the research world, the patients that are responding to the type of interventions that we're applying to them. But there are some few tokens available within the literature that help us clinically to understand which patients are best to see recovery following the spinal cord injury and which ones benefit from the compensatory strategy model. Motor complete spinal cord injury predicts they have the limited ability to recover motor function or functional recovery after their injury. And there's substantial evidence that supports this. If a spinal cord injury is classified as a complete injury, the level of recovery is minimal. However, those with a motor complete injury, we often see they gain 1 or 2 levels below the level of injury due to natural healing. However, those with an incomplete injury are much more likely to see motor and functional gains after the injury has occurred. So we talked about neuromodulation, we talked about spinal cord injury, but now when we combine the two together and we specifically look at the mode of epidural stimulation, we have a few other evidence that exists that led us to this path. So first of all, the definition of epidural stimulation, again, is application of continuous electrical current to the lower part of the spinal cord. And this evidence really started in the animal models where they identified central pattern generators, the CPGs, that exist in cats where they transected the spinal cord, they positioned the cat over a treadmill, and they turned the treadmill on, and the cats were able to perform hind limb stepping motions. So even with a transected spinal cord and no cortical spinal information coming through the injury site, their body was able to respond to this rhythmic stepping pattern, even after a spinal cord injury. That was not completely translatable to humans, unfortunately, but later on, we did identify that these reciprocal movement patterns did exist in humans when we stimulated below the spinal cord injury at the central pattern generator with use of epidural stimulation. And when they were positioned appropriately, upright and on their feet and getting sensory information, we were able to manipulate those motor patterns subsequently. So this picture describes a little bit better of what's happening after a spinal cord injury and then when epidural stimulation is introduced. So the first figure on the left describes the spinal cord with the injury occurring here, with the trauma occurring, and the decreased information coming through from the cortex, the brain. You see down below in the spinal cord that we are getting sensory information coming up, and which is resulting in some motor response occurring. However, the brain input cannot get through the injury site to actually manipulate any sort of neurons below the level of injury. It's more reflexive in nature. Applying epidural stimulation below the spinal cord injury, not at the actual injury site, but at the lumbar enlargement where the central pattern generators are thought to exist in humans, we see a change in pathways available to interact at the spinal circuitry level below the injury to impact the motor outcomes that we see. So it's enabling these dormant pathways that we thought were no longer functional. But now when we apply epidural stimulation, we feel that these pathways now become functional and can manipulate what's happening down the chain. This table is a good example of the amount of work that's been going on over the last couple of decades, from 1998 to 2018, specific to epidural stimulation in humans, and measuring the central pattern generators and the motor responses that occur when stimulation is applied at the lumbar enlargement. In 2018, there were some remarkable papers that were published that demonstrated this ongoing ability for individuals with complete spinal cord injury to actually achieve stepping and standing activities. So in 2018, there were these 5 relevant papers, but since 2018, if you Google search epidural stimulation plus spinal cord injury, you get roughly 52 results. So the field is really exploding. It's an exciting period of time, which is probably why you've heard a lot about spinal cord stimulation for epidural stimulation for spinal cord injuries in the media. So back to the emphasis of today's talk of looking at task-specific neuromodulation training for individuals with spinal cord injury. But what is task-specific neuromodulation? We define spinal cord injury, we define neuromodulation, but what is task-specific neuromodulation? So if we break it down, task-specific really means goal-directed functional practice. You want to learn how to stand, you practice standing. You want to learn how to walk, you practice walking. You want to learn how to roll, you practice rolling. It's very task-specific in its means of practice. As we said earlier, neuromodulation means a targeted delivery of electrical stimulation to enable specific movement patterns. And parameters that are very important in terms of epidural stimulation include the frequency, the amplitude of the stimulation, as well as the location of the stimulation. So when we combine these two together, when we combine these two together, we get what's referred to as a targeted delivery of electrical stimulation to enable function of specific movement patterns. And I apologize, my tab is covering you guys up here. Anybody has any solutions? There we go. See how much that hinders everything. Specific patterns that we use for epidural stimulation, we can categorize it as terms of leg extension for standing or reciprocal patterns for locomotion in humans. So all the evidence that I'm going to show you today, the data, really stems from a case series that was performed within our team at Mayo Clinic. And what we did is we enrolled 2 participants, both with spinal cord injuries greater than 1 year post, and with levels of injuries between C7 to T1. And both injury severities are described as an ASIA A, so a motor complete, so the most severe injury. And what you can see in the picture here is that at enrollment, these participants enrolled in the study, and we performed for 6 months intensive locomotor training, 3 days a week. And locomotor training included body weight support treadmill training, stand training, and trunk balance training. Nothing with spinal stimulation, just physical therapy alone. And what we wanted to do in those first 6 months was to show if recovery could occur with just training alone. We did not see any change in motor recovery with just the physical therapy alone. So at month 6, we implanted the epidural stimulator at the lumbar enlargement. And then for a whole year, we participated, the participants came in and did multimodal rehab, which was task-specific neuromodulation training 3 days a week with our team. So as you can imagine, within the rehabilitation world, there's a lot of variables that we have to consider. And now you throw in the combination of neuromodulation, and it can be extremely overwhelming. What I like to do is really break down the different variables that exist that we as a team had to think about in terms of the progression of our patients as we saw motor improvements change over that year duration. So the variables that were involved in this task-specific training really are threefold in my mind. First is the training environment and the task specificity. Training environment including participating in supine, active leg movement, versus sideline active leg movement, seated training for balance and reaching abilities, over ground for standing or for ambulation, and treadmill with or with a body weight support system to try to initiate that stepping pattern. So the next variable that you have to really consider is the stimulation parameters, the location, the amplitude, the frequency, and the pulse width. And we'll get into the more details about each of those. And then also the rehabilitation strategies, the everyday activities and cues that we give our patients and the variables that we can adapt within our intervention sessions really need to be understood and how they can affect the movement patterns that we see during epidural stimulation. So first, these are the different environments and different modes of therapy that we engaged in. First, the sideline or supine position, where it's a gravity eliminated position, and we can really look at the volitional leg movements. Isolated individual joints versus whole leg movements, where we're looking at flexion versus extension. Next, the trunk seated activities. We're working on trunk flexion or extension, or the reaching forward or laterally. And then again, over ground, working on standing or stepping, using a frame and or a walker, whichever is appropriate. And then using the treadmill system, where we sometimes use body weight support if necessary, where we could really emphasize standing and stepping activities as well. So we just reviewed the training environment and the task specificity, but now we're going to get into more details about the stimulation parameters. So as you can imagine, this is the electrode array that's used for spinal stimulation, specifically for low back pain. It's approved for low back pain, but this is the same device that we used in our trials and others have used in trials across the world. But there are these little boxes here are the different electrodes. So there are 16 different electrodes available. And so when you have 16 electrodes available, you have a wide range of voltage options, a wide range of pulse width, as well as the frequency. There can be millions of combinations that you can really put together, but you really need to be able to identify the patterns of motor activity based on the location, electrode use, but also the frequency and the amplitude that produce those movement patterns. So that we really relied on the evidence that existed from others prior to our trial. And the evidence is pretty robust. And here's a picture of the array that exists with the 16 different electrodes and the corresponding spinal segments that are activated with these different electrodes on the array. And then in 2021, Dr. Hofstauer was able to really map out the spinal cord and then correlate the different parts of the spinal cord to specific muscle groups using color-coded depiction here to identify which part of the spinal cord activates which specific muscle groups. And here's another description or example of this motor recruitment that has to occur. And again, panel A has the electrode where we're activating electrodes at the top of the array, so more proximal, more rostral, versus the bottom of the array, which is more caudal or distal. And you can appreciate this is the hip versus knee versus ankle muscle groups. And when we activate electrodes at the more rostral part of the array, we see more proximal hip group activation, very little distal activation. Now, when we activate more of the distal, the caudal part of the array, further down in the spinal cord, we see a lot more ankle activation. We see proximal activation as well, but we certainly see a difference in distal activation. So this is an example of the motor mapping that we're able to do just based on the location of the electrodes that are used. The stimulation frequency is extremely critical as well. And evidence prior to our study showed that more of a lower frequency pulse train can evoke more of this tonic activity, more activity consistent through all different muscle groups over the same period of time. Versus a higher frequency, you see more of this bursting pattern of the different muscles, more of a rhythmic / step-like patterns that you see in the lower limbs. So this is really important when we talk about epidural stim parameter usage for the different tasks that we're specifying. Here's an example of the stimulation frequency using low frequency. Let's see if I can move this. Low frequency. And you see here, the participant isn't standing. We have full support at the knees and full support at the hips, Arm usage is available at the frame just to help support posture. And no stimulation, so you see no muscle activity occurring here. We turn stimulation on with a low frequency, 15 hertz, and you start to see some activation, what we call threshold activation of some of the muscles. A slight increase in intensity, and we start to see all of the muscles turn on. And now we can see independence at the knee and independence at the hip. He's able to stand independently while using the arms for balance and support. This is an example on how low frequency stimulation parameters are best for tonic extension, such as standing. High frequency does a little bit different. You see these bursting patterns. Here's the left leg versus the right leg. And you can see red is an example showing you leg extension versus blue, which is leg flexion. So you see alternating extension, flexion, extension, flexion. And you can see the differences in the bursting patterns of all the different muscles within the left leg. So there's this coordination between flexors and extensors within leg, but there's also the coordination of flexors and extensors between legs. So left leg extension, you get right leg flexion. Left leg flexion, right leg extension. And you can literally see almost the muscles changing gears and shifting in their bursting duration from a high level perspective, even between limbs. So this is a video where is a good example of using that high frequency, but in the environment of sideline. Gravity eliminated position, we're using the slings to make the movement really easy. Stimulation is turned on and we immediately ask him to start moving the leg in a reciprocal fashion. You see this nice cyclic pattern, a flexion, extension, flexion, extension. Stimulation parameters will remain stable throughout this video. Our cues, our verbal cues on what we're asking him to do will be the only thing that changes. You can see the EMG traces in the background show a nice, robust bursting pattern occurring because we're at 25 hertz with a high frequency. So we just keep asking him to try to flex, extend, flex, extend. Now we tell him to increase his effort. And you can see the magnitude of movement increases substantially. A little uncontrolled, I guess you could say, but then we also ask him to decrease his effort and the magnitude decreases. But it continues. We didn't want him to stop, but we wanted to continue with the flexion extension pattern. And then we ask him to increase it again. So he's able to modulate the momentum or modulate the pattern of movement on his own without changing the stimulation parameters at all. And then we do ask him to stop, and he's able to stop the movement from occurring. Now we get into the overground environment, and we're using the low frequency stimulation. And this is the same example as I showed in the figure earlier. But here we are, assist at the knees, assist at the hips. We're pushing pretty heavy. If you've ever done stand training with someone with a spinal cord injury, a lot of pressure is required at the knees and the hips to achieve this extension pattern. Stimulation's turned on, low frequency, slightly increasing the amplitude, and you can see the hip assist is able to come off, and he's able to support his hips independently at this time. Knees are still requiring quite a bit of assist. We're going to slowly increase the amplitude of stimulation, and we start to see decrease in support of one leg. The left leg is starting to become more independent. Right leg is still needing an assist. You can see the muscles shivering or muscle shaking a little bit in response to the stimulation. But as we climb up in intensity, the voltage, I'm able to come off both knees cautiously. I will say this is the first time we stood with this individual while doing spinal stimulation. So I was excited, but very cautious that his knees were going to just buckle at any moment in time. But unbelievably, he was able to stand there independently at 2.2 volts of stimulation pretty effortlessly. So same day, we took it into the overground using a high frequency. So more of a step pattern that we're looking for. And you can see he's calling out the leg that he's trying to lift up. And again, you see this bursting pattern of the EMG that's occurring through the traces across the screen. Stimulation parameters are all staying stable. His effort and his intent is the only thing that's changing. So we talked about the training environment, we talked about the stimulation parameters, but what about the rehabilitation strategies? How do our cues and our input affect the performance and the movement patterns that we see occurring? So what we did is we did this data collection in the most stable and controlled environment that we had, which was the body weight support treadmill. We didn't want to have to worry about patient falling. We don't want to worry about the clinicians or the trainers getting injured. So we really focused on body weight support treadmill training. And what we noticed is that when we changed two variables specific to intent, so either active stepping or passive stepping, or we changed the body weight support from 60 to 20% body weight support, the movements or the motor patterns changed, requiring significant amount of assist from the trainers, most specifically during that stance to swing phase. So panel A shows you the stance to swing transition phase for the right leg, terminal stance to toe walk to mid swing to terminal swing. And what in the red leg shows you what the experience was that we were as trainers feeling. And at toe walk, we were feeling extreme extension occurring and we couldn't get the knee to bend. So we had significant amount of toe drag, which is demonstrated in panel B through the vertical ground reaction force, which is shoe sensors, sensors that we have within the shoes to measure this ground reaction force. So we saw that with active stepping or with 20% body weight support, the stepping conditions and for the assist level decreased, versus passive stepping or 60% body weight support stepping required increase in a level of assist. So this paper shows you that we took, first of all, the conditions were in this situation, active versus passive, again on the treadmill, and we looked at the quadriceps activity, the motor of the rectus femoris and the vastus lateralis for two participants. And what we did is we asked them to try to step or to assist us in stepping them for 10 steps consecutively. And then immediately after 10 steps, we told them to go passive and just to think about something else, to not try to step and just let the trainers manipulate their legs as necessary to achieve this stepping pattern. The y-axis is amplitude, the x-axis is the gait cycle, so stance versus swing. And the square box around demonstrates or identifies the period of time where that transition from stance to swing would occur. And just from a bird's eye view, recognizing that the EMG patterns that are depicted in these figures are very variable and inconsistent and maybe don't really mimic normal gait patterns. But when we compare passive versus active, you see some differences that emerge. And most notably is overall, throughout the full gait cycle, we saw an increase in EMG activity of the quadricep muscles during passive stepping. Mostly, especially during this transition phase of stance to swing. So that gave us evidence of why we were feeling the resistance to bend the knee and why the leg was going into extension significantly is because of the overactivity of the quadricep muscle. You're probably wondering, well, wouldn't you think activity, greater activity would be a good thing, right? Especially for someone who's completely paralyzed and has no motor activity below the level of injury. And that's a great thought. However, it almost was that the epidural stimulation was controlling or emphasizing that patterns that it almost became like hypertonicity or spastic. But when we asked them to participate and actively step without changing anything within the epidural stimulation parameters, we saw this inhibition occur, which allowed movement to occur more easily as well as more independently. So similar conditions of 10 steps of 60% body weight and then 10 steps of 20% body weight, we saw similar patterns emerge. When they were unloaded, so greater body weight support taken up through the system, we saw a greater amplitude in EMG overall for both participants, which also resulted in this more difficulty for us, the trainers, to manipulate that transition from stance to swing phase. And you can see the dark or solid lines during this period of time was higher as compared to the light or hashed lines which represents the 20% body weight. And underneath this panel here, you can see that there's a statistic difference between these conditions between stance and swing. So it's remarkable how much of a difference there was. I want to emphasize again, not only do we focus on the environment, the spinal stimulation parameters, as well as the rehab strategies that impacted the motor performance, but also recognizing that the training duration of 1 year, as well as the frequency of 3 times a week, and the intensity of this training regimen was really substantial and almost not real life-like. It's not traditional in the clinical practice right now to see patients for that long and that intense and that frequent. But over that 1 year period of time of spinal stimulation enabled task-specific training, we saw both individuals either 100 to 112 sessions over that 1 year period of time. So that intensity is there. And now the next question is, what about the dosage of rehabilitation can impact the motor outcomes? So that's a question to really understand. But we did see a progression over time that we wanted to share and explain what that looked like for the treadmill. So this treadmill video is showing at the very end of 1 year training, stimulations turned off. We're in body weight support of 35%. You see the EMG traces scrolling alongside the video, and you see very little activity. A few bursts here and there, but that might even be just the trainer's hands manipulating and triggering a response through the EMG, the surface EMG. Total assist to do all stepping. We stop the treadmill, take the body weight support harness off, turn the stimulation on, and ask him to walk, and completely different motor patterns of the EMG, very inconsistent, and coordination is a little uncontrolled, but very different than the previous slide. And you can see no assist needed. He's able to step independently on the treadmill. Not a normal gait pattern, very jerky, not a whole lot of control between right and left. However, he does have the flexion extension pattern available. So substantial change from no stim to stimulation after 1 year of rehabilitation. Next will be the overground progression. We're in the environment of overground. We started with the body weight support so we could work on walking overground safely. But at week 1, you can see a lot of assist needed at the legs for both flexion and extension patterns for stance and swing, and a lot of assist at the hips to kind of help with that forward progression. And these are all with stimulation enabled, stimulation use. So toe drag, not a lot of heel contact, but we're focusing on flexion extension, alternating to improve. Week 25, we start to see some independence, specifically in the stance swing, right? The stance phase of the step. I'm still needing some facilitation and guidance to maintain extension during stance, and still assist at the hips to help with that forward weight shift. Week 41, near the end of the study, we start to see some independence. It's able to initiate stance and swing independently, both legs. The hip trainer is still there. Mostly, I can tell you, for guidance, for safety purposes, because you can see it's still not quite safe to walk or ambulate overground independently, but we're there for safety purposes in case a knee buckle or a balance became an issue. However, the flexion extension of the leg, even if it's inconsistent at times, he's still able to generate that reciprocal flexion extension independently over a significant period of time and a significant distance. This was a big progression. The other thing when we talk about rehabilitation and task-specific training is we realize as humans functioning in the community, we need to be able to be multitaskers, right? We don't just float out of bed and start walking down the hallway. We have to be able to sit up, go from sit to stand, and then walk, stop, turn. Multiple different things need to occur at the same time with very minimal thought. So one thing that hadn't been shown is this multitask variant that can be enabled through epidural stimulation. So what we did is we asked the participant to perform 4 different tasks. The first task is specific to standing. So the spinal stimulation that's enabled low frequency, that's best for standing to get that tonic extension. was used. And you can see he's confident in standing. He's able to maintain knee and hip extension. The bars are there just for a little bit of stability purposes, but overall he's very stable in standing. Task 2, we switched the epidural stimulation to the stepping configuration, so a higher frequency, different amplitude. And we said, please just continue to stand. Don't walk, just stand. And you can see the confidence in his motor patterns is a little bit less. He's not quite as stable. He's getting a little bit of knee flexion, but he's still independent. He's not needing any assists to maintain hip and knee extension. But he's able to do that even with the spinal stimulation parameters best for stepping. Turn the stimulator on, or I'm sorry, turn the treadmill on, and he's able to start walking. No change in stimulation, but just turning on the treadmill. So we changed the environment, and he's able to modify his motor output based on what his intent is. Task 4 is to go back to standing. We convert the stimulation parameters back to stand enabling, and he's able again to solidly stand there without any assist, confidently, without any issue. So this is the first evidence of this multimodal rehab, really allowing multitasking to occur using similar stimulation parameters across the board, depending on the task. These results are awesome, right? And even watching these videos over and over again, I realized the substantial improvements that this individual and the other individual gained. However, when spinal stimulation is turned off, both of these individuals who are motor complete injuries return to the original state of paralysis. So unfortunately, we haven't cured spinal cord injury. Epidural stimulation allows these neural pathways to be enabled and to communicate below the level of injury. It allows the brain to be involved in the movements that's occurring, but we haven't cured the spinal cord injury. So we still have a lot of work to do. And recognizing the amount of intense training that's occurred with the patients and their efforts that's involved may not be completely realistic moving forward. So our team had to stop and think, okay, well, other than standing and stepping, what other gains have we seen for these individuals with motor complete injuries that could affect their quality of life or their day-to-day impact of their function from a wheelchair base? And immediately we knew it had to do with the reaching and their trunk stability. So the first portion of the study, phase 1, if you will, included the locomotor training and then the spinal stimulation rehabilitation. And then we took 3 months off, and then we came back and we did a much less intense study where for over 1 year, 2 to 4 days a month, they came back to the laboratory and we focused purely on reaching capabilities with using spinal stimulation. So we wanted to look at the difference between no stim versus stim and their ability to reach forward or laterally. But we also wanted to look closer at the epidural stimulation parameters and their impact on the reaching performance. And down here on panel B, you see a picture of what the forward reach looks like from a mat base versus a wheelchair, and what the lateral reach looks like from a mat versus the wheelchair. I'm sorry, it's a little bit covered up, but we'll get into more detail. So here we are, forward reaching. We have 2 participants. So participant 1 in the top figures and participant 2 in the bottom figures. The y-axis demonstrates distance reached, and the x-axis notifies no stim versus epidural stim, and mat versus wheelchair. So blue means no stim, red means stim. And you can really appreciate specifically for forward reaching, the change in reach distance between no stim and stim was fairly significant. We're talking 10 centimeters to roughly 30 centimeters, give and take, 10 or 20. And you can also see in this picture, exemplary pictures where we see no stimulation reachability, which is not very far. I will give you more information that this individual is a T6 injury. But with stimulation, you can see the drastic change in the ability to reach. The hip flexion, the trunk leaning that occurs, and he's able to return back up to the upright position without assistance needed. So forward reaching is highly successful. We didn't see a very big change in lateral reaching, either between mat or wheelchair at all. So that's something that we need to take forward and try to understand a little bit better. But from a functional standpoint, spinal stimulation seems to enable increased ability to reach forward. So the next question was to look at the different electrode configurations that might enable different reaching patterns. So we looked at caudal electrodes, which are more distal or more further down in the spinal cord, versus using electrodes that are at the top of the array that are more proximal or closer to the head, higher up on the spinal cord, still below the level of injury. And you can see still forward versus lateral, participant 1 versus participant 2. The biggest difference was between stem off versus caudal epidural stimulation. So the lower configuration seemed to enable a greater difference in forward reachability in both participants. Again, not much of a difference in the lateral reaching. So it's the forward reaching that definitely seems to be the most impacted with spinal stimulation. So what I just want to conclude with is that epidural stimulation, when applied and training is provided, motor function gains are achieved specific to standing and stepping. Variables consistent to epidural stimulation, rehabilitation, environment, and strategies can have an impact on motor performance. We have seen improvements, but there still is not a cure. Epidural stimulation is still not a cure, and it's a tool to enable performance of skills when trained accordingly. And last but not least is that there are other gains that can be gained or that can be achieved through epidural stimulation that are beyond standing or stepping and are specific to seated trunk stability. And others are looking at areas in terms of bowel and bladder function, as well as cardiovascular function, which are really critical and important for this population. So I have a list of my references if anybody wants that information, but I just want to conclude with thank you. This is our team here that includes all the participants. You may see a few familiar faces, as well as Dr. Reggie Edgerton and his team from UCLA. They were our collaborators from the very beginning and started off with training and teaching us everything they knew about spinal stimulation. They have moved on to other centers across the world, but we continue to collaborate with them, and they're just critical in the advancement of neuromodulation for SCI. So with that, I will open things up for questions and discussion.
Thank you, Dr. Gill. That was a fantastic presentation. While everyone's thinking of their questions, I'll just put a general reminder out there that if you haven't donated yet, please go do so for the Rochester Marquette Challenge. I just put the link in the chat again. And we do have a question from Joe here, Dr. Gill. He asked, are study participants able to exert supraspinal control of the movements right away, or is there a motor learning period?
Okay, so supraspinal control, so above their injury control. So there's something that we call, I'm having a mind brain. Okay, so there's a difference between a clinical assessment and electrophysiological assessment, right? So we can assess someone's ability to move by observing, palpating, and just looking for movement, right? And that's what we use clinically to determine if they have any movement. But we can also, in the laboratory or in the hospital or clinic setting, we can use electrophysiology, so EMG, or even tools to assess the pathways from the brain down to the leg muscles or vice versa, to see if the pathways are open, to see if there's communication through. So what we know is for those that even have a complete spinal cord injury, like I said, the structures of the spinal cord aren't necessarily transected. They may be bruised and damaged, but they're not completely transected. So there are likely pathways that are existing. They may not be functional, but they are existing and undamaged. So what we have seen, and the term I'm looking for is discomplete injuries. So we have complete injuries, we have incomplete injuries, but somewhere in the middle are the discomplete injuries where we have evidence from an electrophysiological assessment that they can generate activity below their level of injury that's non-functional, maybe not purposeful, but they can induce this activity, which is evident through EMG, even when we don't see movement occurring. So that to us is evidence that there's pathways are available, they're just not coordinated or functional, and we don't see the movement occurring. But we know something's happening based on the intention of the participant through that electrophysiological assessment. Good question. And both of these individuals that I've described today had discomplete injuries.
Very nice. Okay. I don't see any other questions in the chat. I will ask one though.
Sure.
How do you see this research that you've been doing in both the upper and lower extremities impacting our clinical practice, and when might that impact it, in how many years or months?
That's a good question. So today we talked about neuromodulation and specifically the invasive approach. So implanting a stimulator on the spinal cord requires surgery, requires an implanted device that's considered an invasive approach. But there is evidence and there's interventions that are emerging that are considered non-invasive spinal stimulation. So using surface electrode technology that we actually put on the spinal cord in similar fashion as what I described today, trying to evoke excitability within the nervous system to allow communication to go through the injury site from the brain to the muscles. And we're seeing some promising work that's coming through for upper extremity and lower extremity with use of that non-invasive transcutaneous spinal stimulation. Because of the non-invasive work, because it's non-invasive, there's fewer side effects that can happen because of not needing a surgery approach. That may be the type of neuromodulation in terms of spinal stimulation that we see translating to clinical practice earlier. In fact, there's a couple studies that are ongoing right now that are working towards that FDA approval or working towards efficacy, demonstrating efficacy and safety, of course, to try to push for that, FDA approval to use in clinical practice. We use functional electrical stimulation in our clinical practices a lot right now. And so I think as clinicians, as physical therapists and occupational therapists and kinesiologists, I think our background has really primed us in the ability to take the knowledge that we've learned from neuromodulation and implement it into a clinical practice pretty seamlessly. So that may be something that we see happening in the future to improve motor functions for patients with spinal cord injuries. There's still a lot of work to be done to really understand how or why it's happening. But if these studies can continue to show that non-invasive approaches have an impact, not necessarily for standing and walking, but for upper extremity function and hand improvements, and they don't cause any sort of safety concerns, it seems pretty logical that that'll be what gets to the clinical practice sooner rather than later.
Thank you. We have another, do you have time for a couple more questions?
Yeah, absolutely.
Okay. Someone did comment on the epidural stim is FDA approved and asked, do you think there will be some applications for those with CSI approval? You kind of touched on that a little bit.
Right. So the way that I discussed using epidural stimulation today for spinal cord injury for motor activity is not FDA approved. It's all still in the research-based clinical research testing. But the chronic pain syndrome or the neuropathic pain has approved use to use spinal stimulation in clinical practice. It happens to be the same device that we use for both of these interventions, but one's approved and one's not approved for clinical practice. So everything we talked about today in terms of data and progress that we've made for those with spinal cord injuries for function and for motor improvements is off-label use of this device.
All right, we have another one asking, Anna asked, in high frequency stimulation to produce reciprocal movement, is the stimulation alternating based on the map of the spinal cord you introduced, or is it constant?
Good question. The way it's used in the data that I showed you today, it's constant, it's continuous. We do have within the programming of the device, the ability to have multiple programs running continuously. So the best analogy that I can use is if you can send a pulse and they alternate between programs, okay? So we can send alternating pulses from right side versus left side. So they're sent at different times. And then they can have also different levels of amplitude so that we can specifically increase the intensity for the right leg, whereas the left leg may need more or less, and we can accommodate that variability. But the stimulation is even in that pulsing to program mode, the stimulation is continuously being sent. Versus, which I think you're alluding to, is the neuroprosthetic world where they're stimulating just specific locations to isolate a specific muscle, like knee extension, and then tibialis anterior for, toe or ankle flexion. Those programs do exist, and there's some colleagues that are over in Switzerland that are looking at neuroprosthetic use using spinal stimulation for that type of pattern that have seen a lot of success as well. So we're still early on to really understand which style of neuromodulation is necessary. And that's why when I started off the conversation talking about the importance of classifying the injury, really knowing what the patient's level or injury and their severity is really important, because these differences between the delivery of stimulation may be really important downstream and down the road, because likely not every patient is going to need the same type of electrical stimulation, and we're going to have to modify our approach based on their severity. Just like we do with medications, just like we do with gait aids, all kinds of different things. So we have to have that adjustability, and the research needs to be done to prove the efficacy of those different styles of stimulation for the different diagnoses.
And we have one final question here, and then we'll wrap up. Ruth asks, does this have any applicability for high cervical injuries, such as those that might affect the diaphragm?
Good question. So there are a couple of studies that do implant an epidural stimulation higher up in the injury, cervical level. And again, they are seeing some benefits to the upper limb function so like hand or arm motor activity. I haven't seen any data that specifically emphasizes the respiratory function with using epidural stimulation, but that'd be a really interesting aspect and outcome to focus in on. As you can imagine, spinal cord injuries have so many things going on, so many things we want to impact and we want to affect, that there's never a shortage of good questions, most certainly.
Thank you. Well, thank you everyone for attending, and thank you, Dr. Gill, for donating your time and talking to us today. Again, go to the link and donate, you guys, if you haven't yet, and have a good afternoon. I'll hang out for a couple minutes if anyone has any questions.
Thank you, Haley.